Welcome to another installment of Cleveland Clinic eJournal Club. This is Dr. Len Calabrese, Professor of Medicine here at the Cleveland Clinic Lerner College of Medicine, and I also run the IgA Fasenmyer Center for Clinical Immunology. It's always my great treat to call on people, largely that I know, who are doing great work, and to be able to interview them after they've condensed some good science for all of us. So again, welcome back. So today I picked an article that really intrigued me in a recent edition of Arthritis and Rheumatology. It's entitled IgA Plasmablasts are elevated in subjects at risk for future RA. And I have Michael Hollers, one of the authors of this, who is a fixture in this field of the progression of RA and defining at-risk people. He is the Scoville Professor of Rheumatology and head of the division at the University of Colorado. And welcome, Mike.
Thank you, Len. It's a real pleasure to participate in this very unique undertaking.
Good. So let me just preface this by saying, I picked the article because this is interesting to me, and as I'm sure you're going to tell us that, the pathogenesis of RA from at-risk to clinical disease is really a hot area, and mucosal immunity is a hot area in immunology, and this is kind of confluence of it. So why don't you kind of take it away and tell us what these observations are?
Sure, thank you. This work reflects a longstanding collaboration between the SARA group at the University of Colorado and this time with the Bill Robinson Laboratory at Stanford University. As you indicated, we've been pursuing for many years, actually 15 years now, the early pathogenesis, initiation, and progression of rheumatoid arthritis prior to the clinical onset of disease. As a bit of a background, we now know that this disease starts years before a clinician will see a patient with arthritis, and indeed before any signs or symptoms evolve. And the disease can first be picked up through the presence of highly predictive RA-specific autoantibodies, including anti-CCP and rheumatoid factor in combination and at high titers with evidence of epitope spreading. The presence of these disease-specific autoantibodies we now know can identify asymptomatic individuals who are at very high risk for future RA onset. And studies by ourselves and others have shown that these individuals who exhibit these high-titer autoantibodies without inflammatory arthritis, indeed, do have evidence of epitope spreading against the citrulline-aided targets and also elevated cytokines and chemokines. Our hypothesis in the studies have been that if we can understand the early responses prior to clinical onset to known or novel autoantigens, we will be able to understand how the disease is initiated and develops in this preclinical period. Now, as you indicated, there's an increasing body of evidence that supports a pulmonary or broader mucosal site origin of rheumatoid arthritis. And a number of groups have participated and contributed to this, and these groups have shown, first, that there is a long-standing knowledge of the epidemiologic association of RA with lung disease, including smoking, silica exposure, airborne particulate matter exposure. We're going to talk today about IgA antibodies, and we now know from a number of groups that serum IgA autoantibodies to citrulline-aided targets, so-called ACPA or anti-CCP, are especially prominent in at-risk individuals and when individuals first develop inflammatory arthritis. We've previously shown that these individuals who have high-risk autoantibodies exhibit high-resolution CT abnormalities in their lungs, which are, in fact, completely asymptomatic. We've also gone on to show recently that IgA antibodies, ACPA and rheumatoid factor, can be found in this, expressed in the lung of these individuals, even if they're serologically negative. And there's also, as you indicated, increasing understanding of a dysbiosis or altered microbiome in the periodontum and the gut of individuals who are DMARD naive but have very early rheumatoid arthritis. So for this particular study, we utilized the group of individuals that we've been developing here at the University of Colorado and with collaborators around the country. The SARA studies of the etiology of rheumatoid arthritis. As we have previously classified these as at high risk based on the presence of autoantibody positivity and without the presence or history of inflammatory arthritis. And I might add parenthetically that each of these individuals is carefully examined by individuals blinded to their autoantibody status. We sought then to identify in these individuals plasmablasts, and these are circulating cells that can be thought of really as snapshots of an ongoing immune response. And I'll go through the methodology that we use to identify these plasmablasts and what we did then to sequence the antibodies that are encoded by these, and then in our further analysis. It's a very complicated process, which is shown on the next slide, and really takes advantage of the pioneering work by Bill Robinson and his group at Stanford, in which, as is shown on this slide, if you start at the top, you can take peripheral blood, which we did from these asymptomatic antibody-positive individuals and controls, and run it through a flow cytometer and identify plasmablasts. I'll show you in a bit how we do that briefly, and then in a single-cell manner, be able to process these and through deep sequencing methodologies identify which antibodies, the sequence of antibodies and the isotype of antibodies that are made by each one of these single cells. It's a very interesting process, and one that Bill's group has pioneered and really is turning out to be a fantastic way of looking at this particular problem. The next slide in Table 1 just outlines the subject characteristics, and you can see they're really very nicely balanced. Of course, the major differences are that in the antibody-positive at-risk population in the middle, these individuals have autoantibodies, anti-CCP2, anti-CCP3.1, and or rheumatoid factor, and the early RA cases, of course, are also highly antibody positive. Now, in order to identify plasmablasts, on the next slide, we show the basic staining and separation strategy that one undertakes. And it's a pretty straightforward process. If you start on the upper left, you can see each one of these dots is an individual cell, and you can then start to look at these cells and see which ones are the right size. In the third graph over, you can see at the bottom, you stain these cells for various markers. We want B cells, which are the subset of cells under which plasmablasts exist. So you stain away from CD3, which measures T cells, take that box, and then identify further CD19 positive B cells that are alive. You can take those out with Cytox, keep going to the lower left, and just keep working your way through until the end result at the lower right, where we've identified that very small percent of cells that are either expressing IgA, IgG, or IgM as plasmablasts. And so it's a very straightforward process. The next slide really gets to the heart of the finding here, and one that I was really struck by very early on in the study. One of the postdoc, Jennifer Kinslow, who was doing this work, came in one day and said, wow, this is really interesting because these individuals have a lot of IgA plasmablasts, and that's so striking relative to our controls. And this slide then outlines the basic result, which is that if you look at our three major groups, normal individuals, antibody-positive at-risk individuals, or early RA, and just ask what's the proportion of IgA plasmablasts as compared to IgG, one can see this remarkable difference where the antibody-positive individuals in the middle have a much higher proportion of IgA-positive plasmablasts. If you go to the middle, there's a reciprocal decrease in the IgG plasmablasts, which makes perfect sense, and the IgM on the right are indistinguishable from one to the other. Now, notably, there's not a remarkable increase in the number of plasmablasts in either one of these at-risk or early RA groups. What's different is the nature or proportion of plasmablasts that are IgA positive. Now, on the next slide, this is the way I like to present this data because it's very visual and graphical. And you can look again where on the left, normal individuals have this predominance of IgG. And in the middle, we see a couple of different patterns. And some individuals, a subset, do look like they have a normal distribution, but the majority of individuals have this IgA preference, and the line trends down to the lower right. Now, notably, early RA seems to return largely to what could be called a more typical pattern of IgG predominance. And we've actually followed a couple of the middle group into development of early RA, and they seem to have actually switched over to this IgG predominance. So there's an interesting process that we don't know much about yet, but certainly are interested in understanding more. Now, sort of in the same kind of vein, if one looks at the next slide, we did want to see whether or not there was evidence of IgA antibodies in the serum to the various citrullinated targets that we're interested in. And this next slide, figure 1C, basically shows that the individuals who we studied did have IgA antibodies to the citrullinated targets, as well as IgG as their major autoantibodies, consistent with the presence of the IgA plasmablasts. Another very striking feature is shown on the next slide, and this is kind of a complicated analysis, but Bill has taught me as much as I can with regard to this. What you're looking at is an analysis of the plasmablast antibody families that one sees in a single individual, here identified by a number. And there are different families that can be seen. They serve as kind of branch points, as a tree branch is coming off and going to the individual leaves, if you will, at the end. And each one of those dots is actually a single B cell and represents a sequence of a heavy and light chain that's combined. Now, what's striking about this is that these individuals you can look at IgA plasmablast sequences and IgG plasmablast sequences, and a number of these clonal families, if you will, are found both in the IgA and IgG families. So that the implication of that is that these represent ongoing immune responses, snapshots thereof, of immune responses that are IgA-based, and as I'll point out in a bit, IgA is really a mucosal antibody, as well as systemic IgG responses. We, of course, would like to postulate that what we're looking at are ACPA, anti-CCP, or rheumatoid factor responses, similar to what we see serologically. Those are actually ongoing studies, but this is a very striking clonal family analysis. Now, the next two slides really get to some of the basics of the immune response. When one is looking at plasmablasts, you look to see how many mutations are introduced into each cell and ask, is that actually a reflection of a highly mutated or very active immune response? And what one can see here is that the IgA and IgG responses, as we can see them both in clonal and non-clonal families, look very identical. So what we appear to be looking at is an active, highly mutated immune response within these plasmablasts. And the next slide, figure 4B and C, essentially again looks at the number of clonal families per sequences and the complexity of these families, and they look very similar. So whatever we're seeing here in these IgA plasmablasts is very typical, very reflective of an ongoing immune response. Now, figure 5 then takes us one more step and asks, well, we looked at the ACPA responses by ELISA, what about looking at individual peptide responses? And Bill Robinson's group has this very elegant analysis where a bunch of citrullinated target antigens are put down on an array, and you can stain that, or you can pass your serum over that array and ask what is being recognized, and look then to see again whether it's IgG on the top or IgA on the bottom. And looking again at our antibody-positive individuals, a substantial proportion of these individuals have antibody responses to individual citrullinated peptides, both IgA and IgG. So to sort of come to the conclusion, the next slide just asks, what do we know about IgA antibodies? Well, this is a very interesting antibody type. It's the major isoform that's produced at mucosal surfaces, and although the circulating levels are low when we measure them in the blood, one of the classic immunology questions is which is the most highly produced isoform. Turns out to be IgA, but because it goes to the mucosal surfaces, we don't measure it typically. Its primary role, as laid out through the rest of this, is really to regulate the mucosal microbiome, to help maintain homeostasis and protect the intestinal barrier from pathogens. It's a type of immunoglobulin that there's a lot of work going on right now to understand how it recognizes its targets and how that recognition then is transmitted to signals through immune cells and to receptors. And the last point is that the tissue IgA plasmablasts are found predominantly in Peyer's patches in the intestinal interstitium and draining lymph nodes, and also, as we are seeing, they can circulate and allow you to see, if you will, a snapshot of these mucosal immune responses. So the next slide then is the conclusion is that the IgA plasmablast predominance suggests that these antibodies could arise from mucosal immune responses. We propose that these are involved in the early disease pathogenesis in individuals who are at risk in the future, and also certainly that understanding the mechanisms underlying this development by assessing sputum, by assessing other mucosal surfaces should provide us additional insights into how this devastating disease develops. And certainly this also is helping to inform prevention studies, and I would just highlight one prevention trial is based here, run by Kevin Dean and called Stop RA as an NIH-funded placebo-controlled versus hydroxychloroquine in individuals at risk. The last slide is a pictorial of what we've been trying to lay out here during this discussion, is that we believe, based on our studies and of those of many other groups, that there is a mucosal origin of the antibody response, and that this is where things really begin, and it's laid out in the box in the middle. Mechanisms that we're evaluating right now that might be related to how you develop ACPA at mucosal sites. Once you have this process initiated at one or more of many mucosal sites, one then has spread of this to the peripheral blood, and we measure this by serum-based antibodies, and that's what we call preclinical RA. And then ultimately, individuals will, if you will, transfer this immune response into the joints by processes that are also being worked on, and then you develop inflammatory arthritis. As a clinician, you see these individuals now at the point where they come in with signs or symptoms of arthritis. Increasingly, individuals are being seen who are antibody positive without inflammatory arthritis. We think that's a very interesting group for additional study, and certainly we all want to go back in time to figure out how this works. The funding slide is at the end, and this is how SARA is funded by individuals and organizations to which we are very thankful. I'll conclude at this point. Thank you.
Great. Fabulous. And can you go back to Figure 5? Take a look at that heat map picture. So I've looked at that in the paper, and You know, I mean, if nothing else, there's striking difference between early RA and the antibody positives, and it looks like. Do you interpret this as just the progression of epitope spreading and the ongoing maturation of the humoral immune response?
Yeah, that's a very good point. In earlier studies with Bill Robinson's group, we've shown using serum that we've gotten from a military cohort where you have serum from many years prior to onset and then serum from the same individual collected over time before they got our rheumatoid arthritis, that there is clear epitope spreading over that period of time. And these individuals who are antibody positive appear to have a more restricted response, but we would predict as they progress over time, and we have some initial evidence of that from our own prospective studies of individuals that we follow, that you do see this epitope spreading over time. The other thing that I thought you were going to point out is that there are a number of these individuals appear to not have responses to the well-defined citrullonated targets. We're actually particularly interested in those individuals to see are there really novel antigens that they may be primarily responding to, and that's really one of the major areas of emphasis of our ongoing studies.
So a second kind of thing that strikes me is that, I mean, this is, the data speak for itself for the kind of the centrality of IgA here, but you're looking at peripheral blood. So what do you know about plasmablasts, in BAL and crevicular fluids? Do you know anything about that yet? Has that been scoped out?
So what we do know is that there is evidence of IgA antibodies and IgA ACPA in the sputum. We're currently looking at crevicular fluid ourselves, but others have already detected ACPA in crevicular fluid. Now, getting at the plasmablasts, since plasmablasts are really tissue cells, that's a particularly difficult question to address because we are working towards, but we're not yet at the point where we feel it's appropriate to get lung tissue from the individuals who are at risk, or in fact tissue from the large or small bowel. However, the evidence that we have certainly points to local plasmablast production of IgA antibodies that we can measure in the fluid. Getting at the cells directly in those sites is something that we're keen to do, but it's a process of basically convincing ourselves and convincing the appropriate oversight groups that this is the right thing to do.
So I find it of interest that, when you look at patients with fully developed RA or early RA or advanced when they have the disease and they're strongly ACPA positive, that that there is still the presence of IgA and a considerable presence of IgM ACPA. Do you interpret that? How do you interpret that? Is that just ongoing antigen presentation processing? Is it just kind of a cycling of why is there? Why doesn't IgG become the predominant thing after so long?
That's a very good question, and we interpret that as you suggested, evidence of an ongoing immune response. One of the most interesting areas that we think we're getting into now is what actually is going on in the lung of at-risk individuals and also individuals who have active RA. And we've been able to show that recently and have submitted, presented at the recent ACR annual meeting, but also have submitted data suggesting that these antibodies that you see in the sputum are associated with neutrophils that are actively being undergoing a process of netosis and releasing citrullinated antigens to which the ACPA are responding. So we do think that once you have full-blown RA, it's a very systemic disease. It reflects ongoing mucosal responses and also ongoing systemic responses. I would also point to some very intriguing work by Jose Scher and other groups that have suggested that in individuals who have active RA, they have a dysbiotic process. Whether that process is what kicks off the disease is under our own investigation. We're not sure about that yet, but it certainly suggests that there is an active crosstalk, if you will, between the systemic and the local immune response, and that somehow this involves ACPA generation.
I'm interviewing you just literally a week or two post ACR 16, a very exciting meeting where a lot of data was presented that relates to this. And there was a elegant presentation in the day one plenary on oral dysbiosis with this unusual organism, Aggregatibacter actinomycetem comitans, and where some very elegant work displayed that it suggested that citrullination may be ongoing in crevicular periodontal tissues, totally independent of a netosis pathway. Has that even been looked at in lung tissue the way that they have kind of looked at it in periodontal tissue?
Yeah, I think it's really a superbly interesting story. What we're doing is working to identify the bacterial species and or strain, or actually organism, to which one might be able to apply a similar kind of analysis. So I do think that that's a very excellent study to do in the lung. I think what I'd also say is, our studies are pointing us toward this idea that it's not really just one of the mucosal sites at which ACPA can be generated through inflammation and or specific organisms. I think what we're looking at as we work our way through this is going to turn out to be multiple sites of origin in various mucosal locations, each one of which may have its own sort of local microenvironmental changes that lead to these kinds of initial responses. But you're really pointing us in exactly the right direction that we want to go to.
Interesting. So last question, which we're either going to talk about for a minute or I'm going to keep you here all day, but it'll be a minute. So based on your corpus of work and knowing that, you have the SARA cohort and you're doing Stop RA, and there's, several other trials going on around the country, but most of us in practice don't have access to these trials. And it has become of increasing interest and questioning that for patients who are coming and are new onset RA and they're strongly ACPA positive, is there a place in standard of care to counsel that first-degree relatives be screened?
Yeah, it's really a terrific question. So I think that we still believe that first-degree relatives and screening thereof is a research activity. Certainly individuals show up to your clinic. I'm sure you see them increasingly who have ACPA positivity but don't clearly have rheumatoid arthritis. I think that's a kind of a separate question. The screening, though, of populations, including first-degree relatives, for risk of rheumatoid arthritis is something that we're very much interested in, but don't think that it's yet part of standard of care. Now, that said, once we're able to demonstrate that we can do something with a high-risk individual, i.e. prevent, delay, restrain, alter the clinical course of disease, then I think that really opens the door to screening. You are bringing forward a topic about which we have great interest, and we could talk about all day, but I would basically summarize our thoughts as, for a population basis, we think that the most efficient approach is going to be a broader autoimmunity or autoimmune disease screening strategy. Even in patients, first-degree relatives, they have risk for other autoimmune diseases, and we're not sure that just screening for rheumatoid arthritis in a RA first-degree relative is exactly the right thing to do. Other studies are ongoing with Judith James and other collaborators to try to address this question. I think ultimately what we're aiming for is a strategy where the 8 or 10% of the population that develops an autoimmune disease that has autoantibodies, and the majority of which that have been studied, demonstrate preclinical autoantibody positivity in a predictive manner, that we really will be able to consider autoimmune disease screening, and out of that will then flow the appropriate care patterns.
Well, that is a very interesting and informative take on this, and I think that in practice, the more that these studies like yours are discussed, the more this question is kind of just rising, as a kind of a practical issue. So I appreciate your input. So I'm gonna call this to a close. I want to thank you, Mike, for participating. It's been an outstanding presentation. I'll also tell everybody who's listening to this that the first week of April we're going to have our Biologic 7 Summit here at the Cleveland Clinic in Cleveland, Ohio, and Dr. Hollers is going to get a whole hour to discuss this topic in a much broader range. So we hope to see you here, or have you watch it online, or have you watch it afterwards as it's archived, and come back to more eJournal Clubs. Thanks again, Mike.
Thank you, Len. It's been a real pleasure.